Good afternoon. Welcome to the Healthcare Authority's Washington Rural Multipayer Model webinar. I want to thank everyone for joining today. I'm Laura Kate Zeichkin, I'm the Deputy Chief Policy Officer with the Healthcare Authority. Before we get started, just want to make sure that everyone's audio is working and that folks are aware of how they can ask questions throughout today's web meeting. If you have questions, please do not wait until the end. We can address them throughout the webinar, and definitely we will leave some time for questions and discussion at the end. So if you have a question, please put it into the webinar questions panel. And with that, we'll get underway. So again, thanks for joining the Healthier Washington Rural Multi-Payer Model webinar today. We want to provide a pretty high-level overview of discussions and models and potential activities to explore when it comes to rural initiatives and rural health care. Under Healthier Washington, and specifically under our State Innovation Models grant, Healthier Washington has engaged in many different initiatives that think through rural health care. The purpose of our conversation today is to discuss one such exploratory initiative and the opportunity for us to collaborate in the coming year on a potential rural multi-payer model. Really, the Healthcare Authority and Healthier Washington's interest is to engage with MCOs, commercial payers, providers, and other key partners on rural health issues and the potential for building value-based sustainable solutions that support rural communities in the long term. So as many of you on the web meeting today know, the challenges that rural health providers face are numerous. Providers face challenges with serving riskier populations. In rural communities, there are higher rates of morbidity or mortality. Rural communities also tend to be older and poorer, making the payer mix more challenging. Also, rural providers face recruitment and retention issues. Often you're seeing that rural providers may staff primary care and the emergency department. Rural providers' operating margins are low, and providers tend to be undercapitalized, making innovation difficult. And finally, without reaching economies of scale, relationships with larger systems have not necessarily benefited rural providers in Washington. Under Medicare payment models, specifically MACRA and MIPS, as the system continues to shift to value-based purchasing and payment, it's going to be increasingly difficult, increasingly vital to engage in transformation that really re-envisions how rural health and healthcare can be delivered. And in Washington, we believe that the time is right to collectively cultivate a better model than the current system. This model is one that could embrace transformation and one that seeks to support providers as they transition toward meeting the quadruple aim of better health, better care, lower costs, and more engaged and higher experience for providers. We've been executing this vision through a Healthier Washington. So just to back up to high-level health systems transformation activities in Washington State, Healthier Washington embodies our commitment as a state from the governor to payers, providers, purchasers, consumers, and community entities to improve the health of people and our communities. The ultimate goals of Healthier Washington really are to ensure and improve how we pay for services, to make sure that we're paying for value, not volume of services, to ensure that care focuses on the whole person and that we're not bifurcating the head and the body when it comes to health and healthcare delivery. And finally, Healthier Washington is about building healthier communities communities through a collaborative regional approach. We recognize in Washington State that health is local and that solutions to our wicked healthcare problems do require local solutions and local collaboration. At the end of the day, Healthier Washington really is about making sure that the right incentives are in place to encourage collaboration and support providers and communities as we move forward with ambitious aims of better health, smarter spending, and healthier populations. As we think about Healthier Washington and its rural focus, these core strategies that are listed here on this slide can serve rural providers. The strategies also can help to build new vision for rural healthcare and address those key challenges facing rural providers. Healthier Washington believes that through collaborative engagement and collective action, that Washington can lead rural transformation by aligning our managed care organizations, our commercial payers, and providers in a new payment and delivery system that rewards for the value of care delivered, builds on sustainability, supports innovation and transformation, seeks to engage the patient in their own care, and supports clinical providers in doing what they entered the practice to do, which is to serve people and their families. So at the end of the day, supporting and allowing rural providers to move toward population health strategies while being sustainable and vital parts in their community really is the name of the game here. So with that, I'm going to turn it over to our Senior Health Policy Analyst, Gary Swan, who's with the Healthcare Authority and has been leading on a lot of our work around paying for value and also has led on a lot of our rural provider engagement. Gary.
Thanks, Laura. To better understand some of these critical issues, we would first like to provide a little bit more context around rural providers and talk a little bit about their payment and structure. So our rural communities vary from one community to another in their health delivery system resources. There's no predominant structure that can be used to characterize all health delivery systems. And the certification for these provider groups is really derived at the federal level. So federal provisions identify such things as scope of service, method of payment, supplemental funding, and reporting requirements. So providers have different standards at different levels that may impact capacity and ability to report on quality and to perform under new types of arrangements. In terms of reimbursement, largely for our rural providers as critical access hospitals and rural health clinics, Medicare and Medicaid reimburse based off of cost. So Medicare under sequestration is at 99% of cost. Medicaid is at 100% of cost. And then additionally, there's payments that flow to these providers through disproportionate share payments, common payments. And in Washington State, a lot of our rural providers exist within public hospital districts and have the ability to levy taxes for additional support for their facilities. One of the central challenges cross-cutting all these providers that want to implement value-based purchasing really comes down to economies of scale. So as the analogy goes, with one foot on the dock and one foot in the canoe, in our larger networks, they possess economies of scale and pair mixes that make more sense as they transition to new payment approaches, so they can take on much more of the infrastructure build and move into value-based arrangements with fewer MCOs or fewer payers. In our rural communities, the populations are smaller such that MCOs and commercial payers account for diminishing returns in terms of the incentives to engage, especially without alignment between Medicare and Medicaid on cost-based reimbursement. Really the end result being that those that can have participated in gain sharing, principally for access to data, potentially some upside savings, and really experience in value-based partnerships. All the while, fundamental payment encourages providers to drive utilization simply to stay afloat. So the payer mix in these rural regions is much more important, and given the fragile nature and thin margins of our rural providers, there needs to be alignment across our MCOs, commercial payers, and providers to implement any kind of fundamental transformation. As the system moves more toward population health management strategies, these rural payment systems on our rural providers need to keep pace with some of that change. And survivability will depend on their ability to really structure more around quality and value. So as we mentioned, structurally in our rural regions, the principal hospital type tends to be the critical access hospital. The primary care type tends to be the rural health clinic. And as we head towards more isolated regions, there's a higher propensity that the critical access hospital owns the rural health clinic. And oftentimes, the primary care physician will cross-staff between the primary care clinic and the ED. The ED often picks up care gaps or serves as an urgent care for patients. And the providers that serve in the rural communities are more often responsible for the entire care continuum. So this makes recruitment and retention difficult as they have to have higher levels of responsibility that can result in burnout of our rural providers. And really out of necessity, these systems, as you get towards smaller providers, tend to have more integrated staffing models. Looking at 2016 data from the Department of Health self-reported hospital financial data, in terms of the hospital side of things, inpatient care sees around 20% occupancy of available beds. For a critical access hospital, the total number of beds is 25, while some hospitals are licensed for less than 25. In contrast, our occupancy amongst our urban hospitals are closer to 60 or 70% occupancy. This results in our rural regions, at least, for an average daily census of somewhere around 4 patients per day in one of the inpatient beds, with 1.4 admits per patient or per day. In our urban settings, that's closer to 120 average daily census for our urban facilities and 29 admits per day in these urban areas. Additionally, the severity of cases that you see in our rural communities in these inpatient settings has a lower case mix index. So the case mix in our rural communities is 0.7, whereas in our urban hospitals, it's just over 1. So there's lower inpatient utilization for less severity of patients. For our outpatient care, we see upwards of 58 visits per day. In our urban settings, we see closer to 300 visits per day. And in these rural communities, 70% of the gross revenue is from outpatient services. In an urban setting, it's closer to a 50-50 mix. What this all really means is that the financials indicate that driving utilization in an inpatient setting in these rural communities is difficult while vital, but really the locus of care is on outpatient services. And it means that our rural providers have to manage very tightly their financials and perform process improvement, as well as where they can drive innovation and efficiencies. But ultimately, for our rural providers to get paid, especially under our cost-based system for Medicare and Medicaid, it means driving utilization of services, which can be challenging. So with this cost-based reimbursement for Medicare and Medicaid and lower commercial penetration, it makes it challenging for the hospital to operate. And much more often than our urban counterparts, these facilities are under duress. So if our rural hospital were to close, this would have ripple effects for our rural communities. Our providers may leave town due to this cross-staffing and central focus of the hospital as being the key delivery, centralized delivery system in our rural communities. You'd see gaps in care as you have a lot of patients presenting in the ED. And it has systemic effects on the local economy, and it may be difficult to attract more employers. When this happens, it's difficult for our communities, rural communities, to rebound from a hospital closure. And even if they are able to rebound, those gaps in care still remain for key services the hospital provided. We think that a better solution would be to realign our MCOs, payers, and providers in a new payment and delivery system. Really, the opportunity being aligning with primary care while not penalizing the hospital for managing their patient population. Nationally, we see that our leaders have tried to seek out solutions, and between the 2005 and 16 period, 123 rural hospitals have closed and 48 critical access hospitals have closed. Of those numbers, one critical access hospital in Washington State had closed. So MedPAC came out with a report in 2016, and they had two primary solutions, really an ER approach or a primary care model approach that was funded through capacity dollars through grant funding, and then a per visit component. For the ER piece, there'd be a strong focus on outpatient services. And under a primary care model, really for those emergent services, it's triage and transport. Under the REACH Act that was proposed by our national legislators, removing inpatient care and increasing cost-based reimbursement from 101% to 110%, I believe. And the Save the Rural Hospitals Act removes sequester cuts from 2012 to increase those rates back up to 101% for Medicare and increase additional payments for low volume and Medicare dependent hospitals. So while they vary from one to another, they tend to focus around new configurations of services. Under the status quo, we see that the currently exist in this volume-based system, but due to economic trends and broader system trends, it's becoming harder and harder for rural providers to maintain access to healthcare. The system can be fragmented, and financial approaches and fragmented clinical and financial approaches to delivery of care. There's uncoordinated care transitions. There's variations in the delivery system performance without ties to quality. Members are more often left out of their healthcare decisions and unengaged. And really the competing factor is on market share based off of volume of services. In this, we see that there's the potential to transform to a new approach. The delivery system must respond to keep pace with national trends and to maintain their viability. Really developing integrated systems of pay and reward for whole person care, that there's managed care and care transitions, that there's standardization of measurement and performance, that clients are engaged and empowered in their healthcare decisions, and really organizations are aligned and competing on value and quality. CMS has embraced these approaches. Our federal partners have embraced a trend towards population health management and linking those payments with providers and payers for quality improvement. In Washington State, we have embraced those approaches as well. In Washington, we've set similar goals and have embraced VBP transformation. In doing so, we've sought to support practice transformation that helps providers cross the chasm between fee-for-service and value-based purchasing, namely through our Medicaid transformation project, which is underway. As key players, as noted from our payer mix in these rural communities, Medicare has granted waivers to several states through the Center for Medicare and Medicaid Innovation for multi-payer models. So fundamentally, they recognize that this has to be a collaborative effort across multiple payers in transforming payment to drive delivery system transformation. CMS has provided broad flexibility in these models to transform the delivery systems and payment approaches. They recognize that these approaches must be patient-centered and improve on quality and patient experience, accountable for the total cost of care and managing that at a local level, transformative change in the way that care is delivered from a multi-payer perspective, broad-based and inclusive of multiple providers and payers for participation, feasible to implement, providing assurances that this is administratively feasible from a state level, and feasible to evaluate, so performance against a baseline. Structurally, models have really pushed outside of the hospital walls toward primary care and seek to control for total cost of care. So the Maryland model is based off of inpatient and outpatient services, but focuses in terms of quality improvement on pushing outside the hospital walls and focusing around care redesign within the hospital delivery system. The Vermont model is an accountable care organization model, so it sets total benchmarks in terms of spend and pushes down cost trends, and focuses on achieving health outcomes and quality. The Pennsylvania Rural Health Model under development sets a global budget for inpatient and outpatient services, and for those rural providers that participate in the model, they have to submit a transformation plan to a board that sat with payers and providers to review for how they're going to transform under budgeted payment methodologies. And while Maryland is an outlier in terms of some of their rate setting pieces, their early outcomes have been promising, demonstrating savings rather quickly under the implemented model. And they have demonstrated improvement on key performance metrics that are included in the model. But as we all recognize, there are places to improve, and I think that there's opportunity for a Washington state-specific model that recognizes new approaches. So really, this is all to say that nationally there is interest, and from a healthcare authority lens, we're interested in exploring ways to transform the rural health delivery system. We believe that under a new model, we can collectively collaborate and transform the delivery system through development of budgeted approaches that focus on practice transformation. I'd like to pause here for a moment and ask if there are questions and comments around the overarching goals and what we've outlined here before we dive into what we see as goals and opportunities under a new model. So fundamentally, we see 4 key goals under a rural multi-payer model. One is value-based payment reform. So really focusing on patient-centered solutions that reward our providers for the value of care delivered, not for the volume of that delivery, and incent our providers to improve on outcomes for the patients that they serve. This really means focusing our MCOs, commercial payers, and providers as necessary participants around aligned payment and aligned measures that focus on quality and opportunity to share in savings and around population health management. We see as key to this access to data, so providers having integrated and managed data sets so that they can develop care pathways for their patient population that span across multiple payers, that the model is predictable, that there's predictability in the budget and allowing our payers and providers not focusing on the number of visits, but focusing around conversations on sustainability and how do we improve outcomes over time, and really around shared accountability between our payers and providers to perform on quality and value. We also see as fundamental to any kind of new model is developing sustainable solutions for maintaining and increasing access. So putting our payers and providers both at the table to address the unique challenges of our rural health delivery system to maintain and increase access to those essential health services. And that entails care transformation. Delivery system transformation, so seeking to redefine primary care for our rural health populations and providing aligned payment systems that cross-cut incentive structures and regulatory flexibility. From our early engagements through the Washington Rural Health Access Preservation Group and through the Health Innovation Leadership Network, there's a recognition that the health delivery system requires fundamental transformation. Our Health Innovation Leadership Network group that engaged on rural health issues spent their time addressing rural health problems that they face and came to the conclusion that the sustainability of rural health care delivery depends on fundamental transformation and must consider the unique nature of rural and isolated constituents and scarce resources. The transformation must pragmatically embrace health resource availability and redesign the system with enhanced patient engagement, innovative healthcare innovations, and population health strategies, all leveraging modern technology platforms. So really, the impetus behind aligning on payment and quality is around allowing our providers to deliver care the way that they want to deliver care and supporting them in that process. So flexibility to our providers to develop sustainable solutions and develop new innovations that can help to reduce costs and improve care, focusing really around development of primary care teams. So we have a question. Current payment models pay for volume. How do you propose to pay providers as they make these transformations? I think that is fundamentally part of our engagement. Based off of national models, we have some approaches that we think are viable, but these are proposals that we would like to have discussion between payers and providers. In terms of the direct dollars for practice transformation, there's multiple mechanisms as listed here. The fundamental piece of that really being through our Medicaid transformation project in alignment with MACRA as well as other transformation initiatives. So leveraging alignment with what we have already established within Healthier Washington and what's happening at a national level to drive resources to practice transformation for our rural providers. The last piece we see as fundamental is really patient engagement. So delivering the right care at the right place at the right time, and ensuring that our community members within our rural communities are engaged and know their health conditions. And this really focuses around how we get at population health management, that our members are empowered with the tools to be active in their healthcare, that there's engagement with the primary care team, and that our PCP has all of the support around them to deliver that engagement, that care that's delivered outside of rural communities can be directed as appropriate back to the local health delivery system. As a specific example, if there's major surgery that is required for a rural patient, that that patient is able to get their preoperative and postoperative and therapy at their local health delivery system. And as the patient is engaged in their healthcare delivery plan. So based on what we've seen nationally, Washington-specific models may look as the following. We see total cost of care as being a fundamental component that cross-cuts the payment methodology to recognize that if we're focusing on primary care and hospital-related services, that we are accounting for other things that may pop up in the health delivery system, but if we're squeezing the balloon in one area, we don't want to see it pop up somewhere else. For primary care related services and for hospital related services, that there'd be a budgeted type approach. For primary care, this means a per member per month payment amount, PMPM would be adjusted based off of quality performance in future years, and that those clients that don't fall within the attributed population for the primary care component, that they would be reimbursed on an encounter basis, so reimbursed under current contractual relationships. For hospital-related services, that would include inpatient and outpatient services, emergency department services, observation services, ancillary services as well for our critical access hospital providers, swing bed services, which is a long-term observation status that our critical access hospitals can provide. So those would be included in a budgeted approach built off of total patient revenue. So that budget would be trended forward in future years, that each participating payer would have an allocation of that budget, that there would be retrospective and prospective adjustments of the budget, so a reconciliation on some regular interval of the budget, and that the budget would be prospectively adjusted based off of utilization as well as quality and performance. And for those clients that don't fall into the attribution for the budget, we would be reimbursed under a current encounter-based payments and their current contractual relationships. So we have the question, how is PMPM patient-centered? So we believe that a per member per month amount is patient-centered because it allows our providers to really focus and structure their delivery system outside of direct encounter-based payments. So under the current construct, our encounter-based payments have specific provisions that require a face-to-face visit with a primary care physician or other equally qualified counter-eligible provider. That forces certain kinds of delivery approaches for those services. If we move to a population-based payment or a per member per month amount, it allows the provider to flexibly deliver care in a way that makes sense for that healthcare need. And it also means that what we implement in one region may be different than what's implemented in another region, that it provides flexibility to the provider to deliver that care in different ways. So we have the question, how does the PMPM adjust for patient complexity? This is getting into the details of a proposed model. At this stage, we don't have those kinds of details for the specific structure, but we would be interested in input from our payers and providers on how we would account for that and what that means in any kind of conversion. So for the timeline, we're looking at a individual payer and provider meeting in the coming months to discuss proposed constructs, input on how we might want to structure that makes sense for our rural providers, identify questions and concerns, and provide additional details. On February 1st, it's our hope that we would have a meeting with managed care organizations, commercial payers, providers, as well as other key stakeholders on key background and overview of what our goals are for this, to really focus on what this vision might look like and discuss potential models that are of interest to our payers and providers. At that time, we additionally would be interested in future engagements and continued development around this approach. We're also interested in seeking letters from our payers and providers to expressing their interest to continue this conversation. So really at this point, we are high level. We are interested in input. We see that there is a unique opportunity with what's happening at a national level and what we're implementing here under Healthier Washington to align our rural payers and providers on a new approach that makes sense for them. And it's really seeking to host a discussion at this point. And we hope that over this coming months that you'll be engaged and express your interest in having those conversations. So we have several questions. How do you avoid having some systems select healthier and insured patients and refer others to SQHCs? So again, that gets down to details of the model. It would be something that we would be interested in recommended approaches. Right now, structurally thinking, we're looking for alignment and input. So we're looking for alignment with what we're implementing now within Healthier Washington, and we're interested in your input on how we would want to address those kinds of challenges. In a hypothetical model, how would payer participation operate on the primary care side? Each payer contributes X% of the PMPM amount. At this stage, we don't have details on how we would structure that, but ideally, we would have a model that accurately accounts for each participating payer's contribution to the PMPM, that it would be attributed based off of the participating clients and participating payers and their relative allocation of whatever that amount might be. So we have the question, how would you propose a value bundled payment for a surgical procedure? So that, I think, gets towards total cost of care and gets towards pushing outside of the local health delivery system and making sure that we're coordinated between our larger delivery system. At this point, we don't have solid answers on what we would recommend for that, but we're interested in input on how we might structure some of those pieces. So if there's input on how we might structure a total cost of care component around this, or might structure budgeted pieces around this that coordinate on those kinds of elements, we'd be interested in input from payers and providers to see if we can develop meaningful solutions. So I have a question. What is your timeline for hospitals needing to opt into, 1, to participate in the discussion, 2, the model itself? At this point, we don't have definite timelines for implementation of the model itself. We are interested in input. Really, to participate in discussions, now is the time to engage. We're looking to host, again, on February 1st, a convening that brings together our MCOs, commercial payers, and providers to really engage in how we might want to structure something around payment and delivery for our rural providers. I have a question. How does the PMPM calculation factor into Native American tribal clinics billing the IHS encounter rate? Really, at this stage, we're open to additional input on folding some of those pieces into a PMPM approach. What we've learned from our APM4, Alternative Payment Methodology 4 experience, that is implemented on Medicaid managed care services. So would be implemented through our managed care contracts directly with participating FQHCs and RHCs. And that same construct extends to our FQHCs or our potential tribal participants as they are interested. So we are interested if there are inputs, if there are comments that we can fold into the discussion that help to inform the evolution of those payment approaches in upcoming conversations. So I have a question. Does HCA intend to involve ACHs in the upcoming consultations? I think we are interested in having broad-based discussions. We are interested in having all of the issues at the table and having the community-type discussions that drive towards new payment and delivery approaches. So we are interested in having that broader engagement in the development process. To have the question, how would you envision this model intersecting with existing or emerging Medicare ACOs in rural areas? I would underscore that we want to seek national alignment as much as possible. That includes current existing Medicaid ACOs through Medicare shared savings programs or other mechanisms or structures that exist at the national level. I would also add to that we are interested in aligning this with MACRA and MIPS. I think that it makes sense from a delivery system perspective on having that alignment. But again, that comes down to a discussion of feasibility and interest from our collaborators and participants in the discussion on how we could do that. We have the question, currently, Medicaid does not often cover provider costs related to purchasing new technology, even going so far as to ignore its own payment methodologies to bundle procedure codes CMS has specifically developed to pay for increased costs from technology. How can rural hospitals that have such Medicaid volumes sustain technology costs when the program does not pay for them? How does this fit into the proposed model? So This gets back to the fundamental issue around chicken or egg conversations, a practice transformation first or payment delivery system reform. And we recognize that EHR costs are expensive for our rural providers. Maintaining those systems and having integrated data support are increasingly expensive. We are interested in discussing solutions around that. Principally, we'd be encouraged to seek out where we can align with the delivery system transformation mechanisms that we currently have in place through the Medicaid transformation projects, as well as what's happening at a national level. So again, alignment with national incentives and national approaches that help to get some of that capital on the upfront for the delivery system transformation pieces, so you can cross the chasm between fee-for-service to reform delivery systems. So here's the question. You talked about Medicare engagement in other states. What is Medicare's engagement for Washington State, with Washington State thus far? So we've been highly engaged with CMMI through this process. They are very interested in developing solutions for our rural providers. They are very encouraged by the inclusion of primary care in this type of model. They are interested in participating on the long term and having this collaborative discussion with Washington State writ large on how we can transform our delivery system. So I have a question. Do these plans, if successful, doom the future existence of independent primary care practices? So I think we're all faced with challenges around consolidation and independent primary care practices. What we would envision for a model is that we have alignment with those primary care practices that are integrated with critical access hospitals or rural health hospitals, but also is inclusive of those that are not fully integrated. That when there are those independent practices, there still needs to be coordination of services and collaboration at that local level, recognizing the interdependence and the independence of those practices. So we see this potentially as a way to open up the conversation on how do we prevent some of that over-consolidation at a local rural level, and develop those relationships such that those rural communities can better contract and develop partnerships with larger, more urban areas, and have those contracts make more sense for our rural health delivery system. So we have a question. How do I continue the conversation, provide input on a possible model, and get an invite for the February meeting? What are the details for the February meeting? Is that the only or next conversation? So we will be reaching out to our payers and providers, as well as our other key stakeholders, including ACHs, to participate in this February meeting. If you are interested, please follow up via our contact information. We are wanting to have continued conversations in the coming year. Really, what we see as the February 1st meeting is a kickoff for the discussion. During 2018, we will be engaged with those that are interested in hosting this conversation to advance conversations, both at a local level so that they make sense for our rural providers and MCOs and commercial payers, as well as engaging with CMMI through our Healthier Washington commitments and obligations. So we see this as a continued conversation over the course of 2018 that will hopefully culminate in agreements towards the end of, middle end of that year. So we very much appreciate your participation today. We'll hang on here for a few more minutes if there are some additional questions that arise. But this webinar has been recorded, and we'll make sure to send this out to everybody who signed up for the webinar after we're concluded. Great, thank you.